Yeah, I just joined.
Excellent, thank you. So everyone, I'm delighted to introduce Dr. Greg Piazza, who is our host for this evening. Dr. Piazza is a cardiologist at Brigham and Women's Hospital, and he is a part of the thrombosis research group. He works closely with Dr. Goldhaber in that capacity, and he's also on the board of directors for NATF. And Dr. Piazza has kindly agreed to answer all of your questions this evening. Many of you submitted them online, so thank you for that in advance. And I would ask the rest of you use the chat function to submit any questions you have that come up. We are going to mute the lines. It just helps to cut down on background noise so everybody can hear everything okay. So thank you, Dr. Piazza. And do you want to say a few words before we got started?
No, sure. I'm very happy to join all of you on this Tuesday evening after Memorial Day. What better time to talk about thrombosis than now? It's raining outside. There's nothing else I could be doing, so let's talk about thrombosis.
Okay, so we are getting a lot of questions in online, but I thought we would start with one that came up quite a bit over email, which is the status of reversal agents.
Yeah, so
for the NOACs.
So one of the issues with the NOACs when they first came out was concern that there wasn't a easy way to reverse the anticoagulant action of the NOACs in case patients either needed emergency surgery or were having major bleeding. Interestingly, over time, a lot of the companies that made NOACs actually started doing a lot of research into reversal agents, and I'm happy to tell you that there is one FDA-approved reversal agent available, and there's another one that's under review with the FDA. So the reversal agent that's currently available is called Craxbind. That's the commercial name if you were to buy it at the pharmacy. And then it's known as idarosizumab, which is a long name as a generic. But it's only available as a brand name. And the interesting thing is it's a molecule that's made, it's an antibody molecule. It's a protein that's originally formed from humans, but they make it in the lab, so it doesn't come directly from humans. It's bioengineered, and it binds to Pradaxa or dabigatran, which is one of the NOACs, and takes it out of the system. So if your blood is thinned with Pradaxa or dabigatran, as it's also known, this you give this through an IV, this reversal agent, and it simply takes it out of your system. It binds to it and makes it non-functional. So the nice thing about this agent is that you can't give too much of it. You could never give so much of this that you would cause someone's blood to become too thick. With Coumadin, if we have to reverse bleeding in the setting of Coumadin, we have to give something called vitamin K, and then either something called FSP or prothrombin complex concentrate. Both of those are mixes of different clotting factors. If you give too many clotting factors, you can make people's blood too thick. And so that's actually something we've seen in patients that are anticoagulated with warfarin or Coumadin. Sometimes they develop blood clots in the setting of bleeding because they're given too much reversal agent. That's impossible with this reversal agent for Pradaxa. Now, for drugs like Eliquis, which is apixaban, Xarelto, which is rivaroxaban, and Savesa, which is adoxaban, there is another reversal agent that is also bioengineered, and the FDA is reviewing it. But similarly, it's a molecule that binds to the drug and simply takes it out of the equation. It has no function itself but to inactivate the molecule of the anticoagulant you're taking. So again, you can't be made more thrombotic, or they can't go overboard by giving you too much. So in those ways, these are all true antidotes, whereas warfarin or Coumadin does not have a true antidote. You simply try to replace the clotting factors. So this is a very promising thing, and it's going to be one of the things that probably makes the NOACs even safer.
Great, thank you. And can you say anything, even though it's under FDA review, about the reversal agent that will be coming out, hopefully, and when we can expect to see that,
Sure.
and if there's any differences?
So it's called indefinite alpha, and all of the drugs that I mentioned it reverses are drugs that interact with factor 10A. What indefinite alpha is a bioengineered factor 10A, so it looks just like our human 10A, but they've taken away its coagulation function. So it's kind of like a molecule that looks like factor 10, but it has no function. And so it binds to all of these anticoagulants with very strong affinity, but it doesn't affect coagulation. So it reverses the anticoagulant effect of these drugs, but doesn't do anything to the patient. And that's one of the very promising things, and we're hoping that it'll be FDA approved before the end of the year.
Awesome. So kind of you mentioned, not being, over anticoagulated and how safe these reversal agents are. Along those lines, if a patient has to have surgery, what is a safe range, and they're on warfarin, what is a safe range for their INR to be in? And if it's too high and they need emergency surgery, what should surgeons do to get them in a safe range?
So the safe range varies depending on the type of surgery. So if it's something that's on the skin or arm or leg, someplace where they can put pressure if there's bleeding to stop the bleeding, they oftentimes will allow a slightly higher INR, sometimes around 1.5 or so. For neurosurgery, because they can't tolerate any possible bleeding into the brain, they like the INR close to normal, if not normal, at 1.0. For patients that have the need of emergency surgery, they have to give prothrombin complex concentrate, which is an IV mix of four different clotting factors that will reverse the effect of Coumadin. But they also have to give vitamin K, because prothrombin complex concentrate only lasts 4 to 6 hours, and then the Coumadin that's still circulating will thin the blood all over again. But if you give vitamin K, that's the true antagonist of warfarin, then you start to prevent that phenomenon where patients' bloods get thin again.
And in talking about surgery, how soon after being diagnosed with a DVT or PE can someone safely have surgery, in particular a total or a hip replacement?
So that's a great question, and it depends on how urgent the surgery is. So in the first month after being diagnosed with a DVT or PE, patients are very high risk for recurrent PE or DVT if they stop their blood thinner. And for the vast majority of surgeries, you need to stop your blood thinner. So in general, we tell patients that unless it's emergency surgery, they should postpone any elective or semi-elective surgery till at least 1 month after they're diagnosed. If for some reason surgery has to be done during the first month after diagnosis, we oftentimes will place an IVC filter temporarily to cover them during that high-risk period of time. Now, in months 2 to 3, there's still a risk of recurrence if you interrupt the anticoagulation for surgery. So we will oftentimes, if it's really elective, ask patients to wait another 2 months to get to the 3-month point, at which time it becomes much safer to do any surgery. If patients are willing to wait 6 months till when they get off of anticoagulation or they're through the acute treatment period, then they really minimize their risk of recurrent venous thromboembolism. And that's oftentimes what we hope for. But we understand that sometimes there are surgeries that need to happen in, maybe not in an emergency fashion, but in an expedited fashion. And we work to make that possible for our patients as safely as we can.
Say you're a couple of years out from having a DVT or PE, and your surgeon is not aware of your history, is it important to make them aware of your history of having a blood clot? And are there certain precautions that should be taken even years out from having a clot?
Yeah, so it's always important to tell any physicians that you interact with or other healthcare providers that you have a history of venous thromboembolism. It may seem the unimportant part of your history, depending on what the current issue is, but it really is always important. If you are being admitted for pneumonia, you want to tell your doctors your prior history of venous thromboembolism so they can protect you while you're in the hospital. If you're going for surgery, you want to tell your surgeon that you've had a blood clot before, because they'll need to make extra efforts to prevent you from having a blood clot in the setting of surgery, which is quite common. And there are protective medications that can be given to patients and that should be given to patients to prevent these types of blood clots in the surgical setting.
I'm going to mute the line really quick.
I'm sorry.
Okay, there we go. Okay. So another question along the lines of INR. With an increased INR, am I more susceptible to temperatures and fluctuations, particularly cool and cold?
A lot of patients do notice that they feel colder when taking blood thinner, and especially we've noticed it in patients who take warfarin and do have higher INRs. Interestingly, they've looked at it, and the body temperature is not different between patients who are on warfarin and patients who aren't on warfarin. It's just a common feeling that patients describe, but we haven't really noticed that the higher the INR, the colder the patient feels, or the more susceptible. Just being on warfarin with a therapeutic INR, many patients will describe feeling cold. And we don't know why. We don't know why that is. And we are also now starting to see it with NOACs too.
Oh. You had mentioned IVC filters in patients who are undergoing surgery. This question is about post-embolism IVC filters, especially those that were inserted many years ago, in this patient's case 24 years ago. Do they commonly develop problems, and if so, what kind of problems? And are there measures a person with such a filter can take to reduce the risk of any potential problems?
Sure. So IVC filters are oftentimes placed in patients that have a contraindication to being on a blood thinner, or who fail blood thinners, or patients who are bleeding in the setting of having a blood clot. And in that time, they're very helpful. They protect patients from having future blood clots. We know a small number of patients, but a real number of patients will have complications related to the filter. And for that reason, if the filter can be removed, we try to remove the filter after the need is finished. Older filters, ones before the late 1990s, are usually not retrievable. The retrievable filters, ones that can be removed later, came out in the 2000s, and we try to remove those within a year of when they're placed, depending on the particular brand, have to be removed earlier than others. The complications, if a filter does stay in place, are that the filter might develop blood clots and then clot off. And the filter sits in the inferior vena cava, which is the major vein that takes care of recovering the blood flow from your leg. And so you could imagine if that clots off, then it's very hard to get blood flow out of your leg and back to your heart, and so the legs get very swollen. Luckily, that's not a common side effect of having an IVC filter. Other complications of IVC filters are perforation of the inferior vena cava, where the filter kind of looks like an umbrella, and the kind of strut that holds the umbrella fabric, in this case, that pokes through the inferior vena cava, and sometimes it can actually poke into other things in the patient's abdomen, like colon, or muscles or bones, and that can cause discomfort. Other times the filter can tilt, in which case it becomes migrate. It might move into a different vein than it's intended to be in. Sometimes we've seen filters migrate all the way into the heart or the pulmonary arteries. And we've seen filters break, where a piece of it may break off from the rest and travel to the lungs or to the heart. And then finally, sometimes filters can get infected. These side effects are fairly rare, but they do happen. And the main thing for us as providers is to make sure that we constantly reevaluate filters after they're put in to see if we can take them out. They usually come out fairly easy within the first year. If we have to pull them out after a year, there are a number of techniques that can be used to try to pull them out. Some of these fancy techniques can be used to pull out filters that are years old. Otherwise, if a filter can't be removed, if the patient continues to take their anticoagulation, then that will prevent the filter from clotting. And other things patients can do is heart-healthy lifestyle, regular exercise, to reduce the overall risk of thrombosis, which could then lead to the filter thrombosing. So all the things that we tell you to do to prevent recurrent PE and DVT will actually also help keep the filter open.
Wow.
Yeah,
so
long answer to the short.
No, that was a great answer. Would you, so I guess there's no way to know for sure, but for somebody who's had it in for that long, would you recommend taking it out if it could be taken out?
It depends on the reason they have it in. Like, for example, patients who've had a surgical embolectomy, most people will never remove the filter because they're worried that if the patient has another big PE, they may not be able to get emergency surgery so quickly, and it could be fatal. So it depends on the cause of the previous pulmonary embolism or DVT. But if it's causing symptoms, I think it's very reasonable to give a try with one of these. First thing we do is we try to take it out the normal way, which is to use a little hook to snag the top of the filter and then pull it out through a small IV in the neck. If that doesn't work, there are accessory techniques that can be used, more aggressive techniques to remove the filter. And then rarely we go in surgically to remove the filter. But for most patients who have a filter that's not causing any trouble, that has been in for a long time, we just leave it there because the vast majority of patients actually do quite well without complications from the filter.
Well, that's some good news. Does Coumadin cause sun hypersensitivity?
It can. We've certainly seen patients who get rashes to Coumadin. It's usually a reddish rash over the chest, arms, and legs, sometimes on the back. Usually spares the face. And in that case, we have to take patients off warfarin and put them on something else. For patients who have a deficiency of certain clotting proteins like protein C, protein S, or antithrombin, if warfarin is started without heparin as an overlap, then patients can develop a more severe rash or reaction where the skin actually becomes very inflamed and actually dies, and that actually can require skin grafting to treat and is a pretty big deal. That's very rare, though.
So in terms of bad reactions to medications to treat blood clots, we got a question over email about a heparin allergy. And the primary concern is that they're not supposed to be taking any heparin derivative blood thinners.
Right.
So how would the patient get a list of what those medications are, and would an emergency room doctor know if, a medication is a heparin derivative?
Yeah, so the problem with a list of heparin derivatives is there are so many different names. Unfractionated heparin is one of the heparins. Then there are a number of low molecular weight heparins. And sometimes if you're traveling in different countries, the country will have a different name for the medication. Like Lovenox, many of you may have heard of, is called Lovenox in the U.S., but in Europe it's called Clexane. In other countries it has a different name. And so it's very hard to come up with an all-inclusive list. The important thing is to tell your provider if they're thinking about starting you on a blood thinner, that you have a reaction to all heparin-like drugs, and they should know what that means. And they should know not to prescribe any low molecular weight heparins or unfractionated heparins or anything else related to that.
Mm-hmm. It seems like wearing like a medical alert bracelet would be kind of a practical thing to do in this situation.
A medical alert bracelet that says heparin allergy.
Yeah. Okay. So we got a question from a patient whose doctors were not able to find a direct cause for his clot. He's been on Eliquis for 6 months now and has been advised to take it for another year. What can or should he be doing to heal, get off the Eliquis, and discover the true cause of his clot?
Oh boy, that could be an hour right there. So first of all, finding out the true cause of a clot is something that requires a very careful history and physical examination. First of all, you want to know the circumstances in which a clot is formed. Was it in the setting of major surgery, major trauma, immobility, or bed rest? Does the patient have atherosclerotic heart disease? Do they have an infection, malignancy? There's just so many different risk factors that need to be accounted and increase the risk for blood clots and may actually be the cause of the blood clot. Sometimes there's even just slight variations in the way our bodies are made that can predispose us to blood clots. Some patients have veins in their bodies that are not the right shape or being compressed by bones or muscles in the body, and because the veins being squeezed, flow through the vein is not normal and a blood clot forms. So it really requires your providers to do a very careful survey of what might be causing this blood clot. Once the blood clot's diagnosed and once we have a sense of why the patient had a blood clot, we try to make sure that the patient can avoid that trigger. So if it's a birth control pill, we ask patients not to use estrogen-based therapies in the future, and they can use other types of contraception, and if they get pregnant, we can protect them during that setting, since pregnancy is also a high estrogen stage. Sometimes, in about half of the patients, we can't really pinpoint a cause of the blood clot. They have what we call unprovoked or idiopathic venous thromboembolism, and that actually carries one of the higher risks of developing recurrent blood clots. And so once we identify patients as having that, we have to be more aggressive about their protection. Taking blood thinners are critical for healing the blood clot, for preventing new blood clots from forming, especially from the first month to the 6th month after diagnosis. Although if it's a small clot in the calf or in the arm, we oftentimes just give 3 months of anticoagulation. As I mentioned, there's a lot patients can do to prevent recurrent blood clots and to help the healing of their body. Regular exercise, a healthy diet, a diet that's low in fat and cholesterol and high in fruits, fish, and vegetable is very important. Avoiding bad habits like smoking also is critical, and maintaining a healthy weight and low stress levels are all important things that patients have control over to make themselves healthier.
So to follow up on the exercise, do you have any recommendations about what types of exercise are most beneficial and how much exercise is recommended for best vascular health?
Sure. So what I usually tell my patients, depending on what they're used to, if they're used to running, then I have them start back at what they're used to. But for a patient who has been relatively sedentary and develops a blood clot, I ask them to walk either outside, indoors on a treadmill, or in a shopping mall for 30 minutes 5 times a week. When that gets easy, then they can go up to 45 minutes and then an hour. And the ideal amount of time for exercise is somewhere between an hour and an hour and a half. Other types of exercise are also good. Swimming's excellent. Using an elliptical trainer or a recumbent bike, also great. Cycling's great. Although if you're on a blood thinner and you cycle outside, you need a helmet. And a number of other leisure activities are good for building up one's cardiovascular health.
And that's an hour and a half per day, or how many times
per day? But I understand that there are some days my patients might not be able to do it, so I ask them a very modest ask of 5 days a week.
Okay. Is obesity a risk factor for DVT?
It is. It's a risk factor for DVT in a couple of different ways. Just obesity itself is a risk factor for venous thromboembolism, and as the body mass index increases, the risk increases. The other thing about obesity is it likes to kind of team up with other risk factors and make things even worse for patients. So if you're obese and you smoke, it's not just like adding 1 + 1 = 2. They work together synergistically, so it's like 1 + 1 = 8. Same thing as obesity and taking a birth control pill, or obesity and other things that increase the risk of blood clots like inflammatory diseases. It works synergistically. It's an opportunistic type of thing that really increases the risk.
Okay. Speaking of inflammation, we got a question from a patient about inflammation and using lasers to reduce inflammation related to heart disease.
I'm not familiar with any laser therapies used to reduce inflammation in heart disease. What's really exciting right now is the study of medications that specifically lower inflammation in the body, such as methotrexate, which is an old drug that we used to use to treat, or that we still use to treat rheumatoid arthritis. And then other drugs that are being kind of evaluated now in studies that look like by reducing the inflammation in the body, they can actually help reduce the risk of thrombosis. Those studies we should be hearing about within the next few years. Regarding lasers, I mean, lasers have a lot of different applications in heart disease. They're used to treat blockages of the coronary arteries. They've been used to treat varicose veins. They've been used to actually drill holes in the heart muscle to help get blood flow into the heart and to stimulate the generation of new blood vessels in the heart. There are a lot of different applications for lasers, and I have no doubt that there are ongoing studies looking at lasers for modulating inflammation. There have just been no studies in the major journals that are the ones we trust for results that we can really apply to our patients that have come out yet. But we're very keen on anything that can help our cardiovascular patients, and would love to come across a well-powered, large number of patient trial on a laser that could reduce inflammation. That would be fantastic.
From a patient who had a idiopathic DVT and bilateral PE about 8 months ago. They're recovering their full strength and stamina, but have developed some post-thrombotic syndrome, mainly discoloration around the ankles and mild lower leg edema. So they bought compression stockings last week at their doctor's urging, but they're wondering if there's any possible negatives to using them frequently. They feel good now. And is it generally good to alternate compression with no compression?
Compression stockings are very helpful. In general, they're very benign. The only times we see problems related to compression stockings is in patients that are completely bedridden in the setting of like a stroke where they're not moving much. Sometimes compression stockings, if they're not sized appropriately and they're not put on appropriately, can actually cause skin breakdown. But in the average ambulatory patient, there's really not a downside to using them, and they have been shown to help reduce symptoms of the post-thrombotic syndrome. Whether they prevent the post-thrombotic syndrome is kind of still up in the air, but once you've developed post-thrombotic syndrome, they're very important for treating those symptoms and just making patients feel more comfortable.
After the diagnosis of a DVT or PE and beginning treatment, is there a process to be rescanned to look for new clots or to see what the current state of your diagnosed clots are or is?
For patients with pulmonary embolism, we usually do a echocardiogram sometime after 6 weeks from the diagnosis of a pulmonary embolism to make sure that they've not developed pulmonary hypertension or high blood pressure in the pulmonary arteries. And that's a recommendation by the American Heart Association. For patients with deep vein thrombosis, we don't usually perform ultrasounds to see how the clot is doing because we've learned that doesn't necessarily have any prognostic implications for the patient. What's more important is that they're on a good anticoagulation regimen.
Okay, is there a possibility that I am producing new blood clots and are not aware of it?
There's always that possibility, but in general, blood clots that are serious or life-threatening are usually ones that we eventually will feel. So if you're mindful about symptoms in your legs, such as calf pain or cramping, leg pain or cramping, swelling of the legs that's not symmetric, redness of the legs, or shortness of breath, chest pain, lightheadedness, fainting that might be a sign of pulmonary embolism, oftentimes there are symptoms that can be identified that signal us to the possibility of a blood clot. It's rare but not impossible for patients to have silent blood clots, but the literature seems to show that a clot that's not symptomatic may not and probably doesn't carry as adverse an implication as symptomatic blood clot.
Okay, and I think the last question we have is about kind of managing anxiety after being diagnosed with a blood clot. And any words of wisdom for patients who have suddenly developed anxiety after a blood clot and what they might do to help manage that?
Sure. So that's a major challenge for providers and especially for patients after the diagnosis of a blood clot. The real tough thing about these blood clots is they're equal opportunity offenders. It's not like some diseases that we're used to that very clearly affect one demographic or one age group or another. Pulmonary embolism and deep vein thrombosis can affect patients who are young and otherwise healthy. They love to affect patients who are ill in the hospital. They're not prejudiced to certain age groups, certain genders, or certain demographics. They like to affect everybody that they can. And one of the tougher things is when patients who feel pretty healthy and don't have a lot of medical problems develop a blood clot, it sends a psychological shock to their system. They may have been under the impression that they're very healthy, and now they have to deal with this disease that they're told is potentially life-threatening. And that becomes a huge challenge. The sort of, for young patients or middle-aged patients who haven't spent a lot of time thinking about uncomfortable topics like the transient nature of our lives and the fact that we're not here indefinitely, it can be a real eye-opener, and it can be something that's very difficult to think about. We like to go through life thinking that, illnesses are something that happen to other people and they don't necessarily happen to us as long as we mind our own business. But when something like this happens, it's a reminder that there are real things out there that can happen to people even randomly when they're otherwise healthy. And so that becomes very difficult. After a blood clot, patients oftentimes have to go through a period of adjusting to their body where they may continue to have chest pain or leg pain or difficulty breathing, and they don't know whether they have a new blood clot or if it's just healing from the old blood clot. And so they really need an attentive and careful clinician who can talk them through this difficult time. Often it's very helpful to have either a therapist or counselor or to go to or attend a support group that focuses on venous thromboembolism. One of the most therapeutic things for any illness, but especially for venous thromboembolism, is just to immerse yourself in others who have the same illness. You get a perspective from people who've gone through this process of learning about their body and are further along than you, can help coach you through it. You learn invaluable tips about living life on anticoagulation and living life after a blood clot. And the worst thing you can do is just bury yourself in solitude, worrying about these blood clots. It's far more productive to talk to others and share your experiences. It's therapeutic and should be encouraged as much as possible.
Great. Well, thank you for that very thoughtful answer and strong support of our support group. We did get one final question to trickle in about elevating legs when they swell up. A patient has heard conflicting things, that it's good to elevate them when they swell up, but also that if you keep them up for too long, it can cause issues from lack of blood. Are there any recommendations regarding that?
Yeah, I think by and large, elevation is very helpful for patients who have swelling. I usually recommend to my patients to elevate their legs 30 minutes 4 times a day. Um, and that's usually what most providers recommend as helpful to patients. When they sleep, it's good for patients who have swelling to put their legs up on a pillow or two to help enhance the drainage. Unless you have really, really severe arterial insufficiency where the arteries to your legs have very severe blockages and you're not getting much blood flow to your legs, there shouldn't be any problem with elevation.
Okay. Great. Well, that is all of the questions that we got, and I think you did such a wonderful, thorough job answering them, and we certainly covered a lot of ground. So thank you very much, Dr. Piazza, for joining us. This was recorded, so we'll go ahead and send